Assalamu alaikum. Let's dive into immunology. Start with my intro where you will hear a murmur. Can you tell me the name of this murmur? Okay. Okay, now immunology first with spleen. Okay. Spleen, uh, what is the underlying pathophysiology leading to sepsis? What is the underlying pathophysiology leading to sepsis of a gram-positive cocci in patient with extensive surgery for multiple gunshot wounds to the abdomen? Impaired antibody-mediated phagocytosis. It is due to impaired antibody-mediated phagocytosis. Much of this dependent on splenic macrophage on the and the generation of splenic opsonizing antibodies and the generation of splenic opsonizing and the generation of splenic opsonizing antibodies. Okay, the patient is likely has splenectomy, making him or her more susceptible to encapsulated organism like SHIN, Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitis. What are the three vaccine? What are the three vaccine should patients receive prior to undergoing splenectomy? Antipneumococcal, Haemophilus, and meningococcal vaccine, and yearly influenza vaccine. These are the vaccine like Shin vaccine, Streptococcus pneumonia vaccine, pneumococcal vaccine, Haemophilus influenza vaccine, and Neisseria meningitis vaccine, and yearly influenza vaccine. Due to risk of overwhelming sepsis, patients should also have daily oral penicillin prophylaxis until 5 years of age or for 3 to 5 years after splenectomy. Very high yield. Recommended vaccination: pneumococcus PCV20 followed by PCV15 and PPSV23. PCV15 15 valent pneumococcal conjugate vaccine. Sorry, PCV20 20 valent pneumococcal conjugate vaccine or PCV15 and PPSB 23 valent pneumococcal polysaccharide vaccine and one dose of Haemophilus influenzae vaccine HIB vaccine, and for meningococcal vaccine meningococcal quadrivalent vaccine and vaccine against serotype B, and revaccinate every 5 years and revaccinate every 5 years. Other vaccines should be given according to age appropriate guidelines. Patients who undergo splenectomy are prescribed to antibiotic to take immediately when they develop fever. It is amoxicillin clavulanic acid or levofloxacin. Patients who undergo splenectomy, uh, they should always keep this antibiotic in them because whenever there is an infection, if they do not take antibiotic immediately, as there is no splenic, their infection will be much more serious. Patients with splenectomy often have secondary thrombocytosis, reactive thrombocytosis. Typically, platelet counts normalize after weeks, but a minority of the patient, but a minority of patients have a thrombocytosis. Minority of the patient have a thrombocytosis for months or years after surgery. Now, B and T cell disorder. This box is very high yield. B cell disorder is ABC, A, B, C. severe combined immunodeficiency disease, selective IgA deficiency, and Bruton's gamma globulin or X-linked gamma globulinemia. Okay, for Bruton's, first start with ABC. In selective IgA deficiency, B cell is normal, IgG is normal, only the IgA deficient and the rest of them is normal. In selective IgA deficiency, only IgA is absent and rest of the parameter is normal. G, A, M, E, and another is D. D is not that significant, so in the game their A is absent or low. In Bruton's, it is due to B cell. B cell is absent, so in plasma cell is absent, so immunoglobulin G is absent. All the immunoglobulins are absent. G, A, M, E is absent. So in Bruton is a big player, big gamer, so everything is down. Now CVID, in common variable immunodeficiency disease, B cell count is normal. In common variable immunodeficiency disease, B cell count is normal, but everything, the game is on, the game is low. B cell count is normal, but the game is low. In hyper IgE and Job syndrome, only E is higher and everything is normal. In hyper IgM syndrome, IgM is higher. Hyper IgM syndrome, hyper IgM is higher, B cell count is normal, and M, GA and E is low. This is slightly atypical, and the rest of the thing is easy to remember. Okay, now in B cell disorder, there is propensity of happening key feature is encapsulated bacterial infection and interviral infection. Uh, in B cell disorder, selective IgA deficiency, Bruton's, and CVID, common variable immunodeficiency disease. In here, there is encapsulated organism like Shin, Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitis. These infections are much more common. These infections are much more common. Interval infection is much more common. Immunoglobulin G is low and decreased vaccine response. In T cell combined B and T cell disorder, early less than 4 to 6, failure to thrive viral, bacterial, fungal, and candidal infection, failure to thrive, decreased leukocytes. In T cell disorder, T cell disorder is in T cell or combined B or T cell disorder is DGORS syndrome. DGORS syndrome is T cell disorder. Ataxia telangiectasia, these are the B and T cell disorders. SHAW, severe combined immunodeficiency disease, hyper IgM syndrome, ataxia telangiectasia, and viscotality syndrome. These are B and T cell disorder, and DGORS is only T cell disorder. In here leukocytes is low. In phagocyte disorder CGD and leukocyte adhesion test, phagocyte disorder CGD and leukocyte adhesion test, and complement disorder, Neisseria infection and autoimmune disease, decreased CD50, C1q deficiency and terminal complement, C5 to C9, failure to thrive is usually present in T cell disorder due to chronic diarrhea and increased metabolic needs to recurrent infection. Poor vaccine response usually involved in B cell disorder. Poor vaccine response is usually B cell disorder. Young children present with features of disseminated TB following administration of the BCG vaccine. Young patient. Features of disseminated TB following administration of the BCG vaccine. It may be due to interferon 12 receptor deficiency, or because there is decrease in interferon gamma. Common pathogen intracellular salmonella and mycobacterial infection. Clinical features of disseminated disease TB the following BCG vaccine and fungal infection and diagnosis decrease interferon gamma. Treatment is interferon therapy, antibiotics and interferon therapy. So young patient disseminated TB following BCG vaccine, it may be due to interferon 12 receptor deficiency. Okay, transient hypogamma globulinemia in infancy. Transient hypogamma globulinemia in infancy, prolonged age more than 6 months, physiologic IgG nadir, mostly asymptomatic, may recurrent respiratory infection, there may be atopy, decrease IgG with or without IgA or IgM, normal antibody response to vaccine, normal B and T lymphocyte observation, self-resolution, and early childhood. Maternal immunoglobulin G contribution, physiologic nadir, newborn immunoglobulin G contribution. What is the likely diagnosis in 8-month-old infant with low serum IgG and normal IgM or IgA? Low 8-month-old infant, low serum IgG but normal IgM and IgA. It is transient hypoglobulinemia in infancy due to decreased maternally derived IgG by the 3 to 6 month, usually resolved by 12 months of age. Now, B. Bruton's A-gamma globulinemia or X-linked A-gamma globulinemia. In Bruton's BTK gene abnormality, Bruton tyrosine kinase mutation in the defective Bruton tyrosine kinase. In here, what happened in Bruton's? In Bruton's, everything is low. B cell low, and all the game is low. So impaired B cell maturation, impaired immunoglobulin production, impaired B cell maturation, and impaired immunoglobulin production. There is recurrent sinopulmonary and GI infection at age 3 to 6 months, chronic enteroviral infection, small or absent lymphoid tissue, tonsil, adenoid. Recurrent sinopulmonary and GI infection at age more than 3 to 6 months. Lab is decreased immunoglobulin and decrease, and in here decreased CD19 on B cell and normal T cell. Flow cytometry decreased CD19 on B cell and normal T cell. Treatment is immunoglobulin replacement therapy and prophylactic antibiotic. Immunoglobulin replacement therapy and prophylactic antibiotic. In CVID, B cell is normal, B cell is normal, but absent game. Abnormal differentiation of B cell into plasma cell. Abnormal differentiation of B cell into plasma cell decrease immunoglobulin production. In clinical finding, classically 20 to 40 as puberty, recurrent respiratory infection, recurrent GI infection, salmonella, campylobacter, giardia, chronic disease, autoimmune, RA, thyroid disease, pulmonary bronchiectasis, fibrosis, and GI, chronic diarrhea, IBD-like condition, decreased IgG, IgA, and IgM, no response to vaccination, immunoglobulin replacement therapy, CVID should be suspected in adult with recurrent bacterial infection versus other cause of immunodeficiency which is present in childhood. Occurs in adult 20 to 40 and adolescent around puberty. Uh, What is the test to diagnose common variable immunodeficiency? Quantitative measurement of serum immunoglobulin. Quantitative measurement of serum immunoglobulin is used to diagnose CVID, which immunodeficiency is characterized by no B cell maturation. It is X-linked Bruton gamma globulin versus CVID has poor B cell differentiation, but B cell is present. B cell present, but in Brutons B is absent. In Brutons B is absent. Now, SCID, severe combined immunodeficiency disease. It is the B and T cell disorder, gene defect leading to failure to T cell development and B cell dysfunction due to absent T cell. B absent due to absent T, and T cell absent due to gene defect causing leading to failure of the T cell development. It is X-linked, it is autosomal recessive, there is recurrent severe viral, fungal, and opportunistic infection, failure to thrive, and chronic diarrhea. There may be stem cell transplant. There may be stem cell transplant. What tests are used to diagnose SCID? Quantitative PCR, decreased T cell receptor excision, cries, circle, decreased T cell receptor expression circle, part of the routine newborn screening, absent T cell, and chest X-ray show absent thymic shadow. Absent thymic shadow, like D. George, absent thymus in SCID, severe combined immunodeficiency disease, lymph node biopsy show absent germinal cell, absent thymus, absent germinal cell. Selective IgA deficiency, most common primary immune deficiency, usually asymptomatic recurrent sinopulmonary or GI infection associated with autoimmune disease, celiac disease, atopy, asthma, anaphylaxis during transfusion, low or absent IgA, and normal IgG, IgM level, and B cell, normal IgG, IgM, and B cell. Supportive care and medical alert bracelet, and sh- um, should receive blood product washed. This patient should receive in selective IgA. This patient should receive blood product washed of residual plasma or from IgA deficient donor. This patient should receive blood from IgA deficient donor or washed of residual plasma. Okay, now the hyper IgE syndrome. In hyper IgE syndrome, IgE is higher and the B game in B game all of them normal, and E is higher. Autosomal dominant defective Jackstat, hyper IgA Jackstat. Impaired T helper 17, impaired T helper 17, decreased neutrophil and proliferation and chemotaxis, severe chronic eczema, non-inflammatory cold, abscess, staph, and candida, recurrent sinopulmonary infection, dysmorphic faces, broad nose, prominent forehead, and retained primary teeth. Hyper IgA, high eosinophilia is and normal leukocyte count with decreased T helper 17. Supportive screen care and antibiotic prophylaxis and treatment. Now leukocyte adhesion disorder. Leukocyte adhesions 18, defect in CD18 containing integrin, defect in CD18 containing integrin, impaired leukocyte adhesion and endothelial transmigration, impaired leukocyte adhesion and endothelial transmigration. Clinical feature: skin and mucosal infections, cellulitis, periodontitis without pus formation, impaired wound healing, delayed umbilical cord separation, age more than 3 weeks, and leukocytosis and neutrophilia. Now CGD, chronic granulomatous disease, X-linked recessive mutation of NADPH oxidase, X-linked recessive mutation of NADPH oxidase, impaired respiratory burst and decreased reactive oxygen species, inhibition of phagocytic intracellular killing. inhibition of phagocytic intracellular killing. A clinical feature is recurrent infection with catalase positive organism, bacteria, catalase positive bacteria, and fungi. Lungs, liver, lymph node involvement. There may be diffuse granuloma, GI, and genitourinary. And in CGD, dihydrorhodamine test, flow cytometry is preferred, and NBT testing is preferred. These two is preferred. Prophylaxis, TMP, SMX, itraconazole, IGRA, and hematopoietic stem cell transplant is curative. TMP, SMX, itraconazole, and IGRA is prophylactic, and hematopoietic stem cell phagocytic cell filled with bacteria due to ineffective intercellular killing. They are frequent finding of wrong stain. Live bacterial vaccines such as BCG vaccine should be avoided in CGD. Chronic granulomatous BCG vaccine is avoided. Can induce severe infection. Live viral vaccine as well as inactivated vaccine are live viral vaccine as well as inactivated vaccine are safe. BCG vaccine is avoided. It can induce infection. And the finally, patients also have impaired ability to degrade inflammatory cytokine which predispose them inflammatory condition IBD, diffuse granuloma formation. In CGD associated IBD, there is pigment laden histiocyte, and are characteristically seen on histology and represent lipofuscin accumulation due to impaired lipolytic activity. In here, you can to reduce the risk of infection, TMP, SMX, and antifungal intraconazole can be given because breakthrough infection involve resistant bacterial and fungi organisms. Patients generally should undergo biopsy and area active prior to infection before initiating the empiric antimicrobial therapy. So this is all about the first part of the immunology regarding usmle inner circle, first part of the immunology regarding usmle inner circle. And can you guess the murmur? Okay, do you want to hear it again? Okay, okay, put it in the comment box.